Yes, so hello everyone, good evening to all of you. Yes, so good evening. I hope your preparations are on track. And as I start, also, I wish you all the very best. And I want you to stay relaxed, especially on the day of the exam, and just give your best performance, and it will be good enough to get us what we deserve. Right. So UPSC exam has always been relatively clinical, relatively questions related to the outcome, more practical approach to medicine and medicine related diseases. So this year's questions paper was no difference. It was a good mix of little old and little new. Yes, there were few topics which are probably, I used to teach, give more importance couple of years ago. So we'll just go through the questions from nephrology and rheumatology. As we already always tell you that in medicine paper, in NEET PG paper, you will always see that questions from cardio and CNS are likely to be little higher level. But nephrology and rheumatology tend to be very basic related questions, which most of you can answer if you can just apply the knowledge that we have. So it's not much of a rocket science that we want to just apply the knowledge that we have, and we will be able to reach the diagnosis. As I keep telling, all the questions will not be like verbatim from notes, but based on the application. Starting with number 1. We always joke in class that glomerulonephritis is one of the most common questions in every exam that you have ever attempted. And unfortunately, it is one of the cases which probably you have never seen during 5 years of MBBS. तो मैं कहता हूँ कि इतने बार हमें एग्जामिनर ग्लोमेरुलोनेफ्राइटिस के बारे में पूछते हैं कि स्टूडेंट को बेचारे को सपने में भी जीएन आने लगता है. बट हकीकत यही है कि जीएन सपने में ही दिखता है और रियलिटी में बहुत रेयर डिजीज है. But if you happen to be having a patient of glomerulonephritis, we want to highlight which are the poor prognostic factor in glomerular disorders. In glomerular disorders, we are always worried about risk of progression to RPG, worsening of the symptom. Among the thing, we will say that the female gender is not a poor prognostic factor. It is not a poor prognostic factor. The female gender tend to have lower protein, lower muscle mass, lower solute production as compared to the male. So it's usually it is the male gender tend to have more severe disease. The males tend to have more severe disease. The exact reason why it is there is not clear, but the hypothesis is like that in the male, the solute production, the protein intake is much more. The risk of the infection, the risk of toxin is higher in the male, though in autoimmune disease, females may take a upper role. But because of the treatment with immunosuppressant, the prognosis is usually favorable. In the female, we tend to think of more autoimmune causes, but due to availability of widespread immunosuppression, the prognosis has now become better in the female. So second one, having hypertension. So hypertension, that means patient having a nephritic presentation. Yes, having a nephritic presentation is associated with increased risk of RPG because there is relatively rapid decline in the GFR, which can progress to increased risk of RPG. So that definitely associated with mortality. Hence, it is a poor prognostic factor. So 2 is there. Persistent and severe proteinuria. So lack of response. So what we say, when the patient is refractory to treatment, when the patient is refractory to the treatment, there are going to be persistent symptoms. There are going to be persistent disease process, tend to have a poor prognosis, and elevated creatinine at the level of presentation, because creatinine correlates with the severity of nephron loss. The creatinine level correlates roughly with the severity of nephron loss, of severity of dysfunction, we can say. So I will say that what are the poor prognostic factor? One, based on gender, males tend to have poor prognostic factor. Nephritic is worse than nephrotic because risk of RPGN is more. If patient is refractory to treatment, comes with severe diseases onset, or number 5, it could have been correct if the patient came with atypical presentation. Because whenever a patient comes with atypical presentation, then of course they are going to delay the diagnosis. Atypical presentation delays the diagnosis and hence associated with poorer prognosis. And also we can say, if the renal biopsy shows crescentric GM, when there is presence of crescent formation on the biopsy. Crescent formation on the biopsy associated with risk of poor prognosis because it indicates severe damage to the GBM. It indicates severe damage to the GBM and the surrounding vasculature. So we must know all the correct options. All of them are there. So in our patient, as you have answered rightly, Sahil and Nimisha, the correct option is option number C. Right? Brings us to the second question of UPSC exam. Which of the following is an indication for renal biopsy? Again, let us understand why it is a little older question, because renal biopsy is an invasive procedure. It is an invasive procedure, hence it is not preferred. And also availability of better imaging and better serology. Better imaging and better serological studies, that is antibody test, is available. Serological testing is available and hence biopsy is not routinely done. I am sure you have seen hardly a renal biopsy in your entire 5 years of MBBS. You are rarely going to see biopsy. But as we have discussed in class, in acute renal failure, when we are going to do biopsy, let us see. In the patient with nephritic syndrome, I said the diagnosis, probable diagnosis can be based, on the antibody present. So because of better serological testing, we don't require the biopsy in all nephritic syndrome. We don't need that. But we know in the nephrotic syndrome, there is going to be no antibody. Here, the gold standard for diagnosis remains biopsy. So in nephrotic syndrome, we may have to do biopsy because these people have no circulating antibody. So that will be indication. Any patient who is having unexplained disease, okay, patient having unexplained etiology. So I can add to this, if the patient is having unexplained proteinuria, unexplained hematuria, then also we must do biopsy. Unexplained diseases, hypertension, proteinuria, hematuria, we must do biopsy, and to assess renal transplant dysfunction. In renal transplant dysfunction, the biopsy is important to differentiate between drug toxicity. One of the common immunosuppressive agent, tacrolimus, cyclosporin group, and the cyclosporin, calcineurin inhibitor induced toxicity and rejection. Biopsy is an important test. Biopsy is an important test. So here again, you want to look at option number C. 1, 3 and 4 you want to choose. So in there we have got extra point is that when the patient has got progression to RPGN, clinically when the progression to RPGN is present, then also we will go for the renal biopsy. So both questions are actually very similar based on the outcome. The logic is the same. I will do biopsy when I don't have any serological test to diagnose. I will do biopsy when symptoms are persistent or patient is having CKD of unknown origin, or after transplant when patient comes with renal dysfunction. The only way to differentiate drug induced versus rejection is to do biopsy. And that is why correct answer is option number C. Okay, so take it forward to question number 3. This I'm sure that most of you have definitely got the answer. When the patient is a 40-year-old female who has come with the nephritic range proteinuria found to have low serum complement level. We have repeatedly discussed this class, the raw serum complement level in the patient with glomerulonephritis. We are going to further divide it into the two groups. Low complement level in glomerulonephritis, when the complement level is initially low but it returns to normal within 2 to 4 weeks, and the causes when the complement level is persistently low. When the complement level is persistently low, we have discussed this point. Low complement level indicates either there is infection or inflammation in the body. Infection or inflammation in the body. So let us understand. The returns to normal, it indicates post-infective causes of GN. It indicates post-infective causes of glomerulonephritis, which can be post-infectious GN. So to infective endocarditis also. We learn infective endocarditis. It is an immunological criteria. Duke's criteria, immunological criteria, is the infective endocarditis. It can occur in the PSGN. It can occur in infective endocarditis, hepatitis B and hepatitis C infection. Hepatitis B and hepatitis C infection. But persistently low indicates autoimmune disease. Persistently low indicates patient is having autoimmune disease, that is most commonly SLE. The most commonly it is SLE. So direct answer you get in SLE also. In post-infective endocarditis, we will get persistently low. The complement level can be seen. So as I mentioned, the old topic here relatively is mesangiocapillary glomerulonephritis. If you look at the pathology connection, it is still taught in medicine on the immunofluorescence. When you get complement deposits, complements deposit in the mesangiocapillary pattern. Complement deposits in the mesangiocapillary pattern. Immunofluorescence study shows C3 deposits in the mesangiocapillary pattern. Hence, they are now known as C3 associated glomerulonephritis. They are now known as a group where they are C3 associated glomerulonephritis. In majority of them, majority of C3 associated glomerulonephritis have low complement levels, but there are no circulating antibodies. So what we discussed in class is serologically, antibody present gives you probable cause of nephritic syndrome. But antibody is not there, only complement level is low, then we call it as the C3 associated GM. So that is also having low complement level. So the correct answer here is option number D. All four have got low complement level. So mesangiocapillary is an old terminology. Now we prefer to call it the C3 associated glomerulonephritis, which I am sure you have discussed in our MCQ. In pathology class, we have put it clearly. In the pathology class, take this forward. Which of the following are features of autosomal dominant polycystic kidney disease? Autosomal dominant are also known as adult form of PKD. Also known as adult form of PKD. Right? Discussed in class that in polycystic kidney disease, they most commonly manifest between 30 to 50 years of age. Most commonly manifest between 30 to 50 years of age in the APKD1, that is defect in the polycystin 1 gene on chromosome number 16. Polycystin 1 gene on chromosome 16. They can also present after 50 years if they are patient with APKD2, where there is defect in the polycystin 2 gene on chromosome number 4. So the presentation is varied. It is middle-aged person or elderly person presents with CKD, that is adult onset of polycystic kidney disease. But all of them, what do they have? They have got multiple cysts in multiple organs. They have got cyst in multiple organs. It is present in the liver, in the lung, in the pancreas, arachnoid membrane, even seminal testicular membrane, there can be cyst present. That is rare. The clinical manifestations are both renal and extrarenal due to the cyst in other organ. So we know in the MCQ, the most common extrarenal manifestation is obstructive jaundice. Obstructive jaundice due to cyst in the liver. Due to the cyst in the liver, there can be both renal and extrarenal disease. And as we saw in the first MCQ, the progression in men is always considered more than the women. Men tend to progress more rapidly than the women based on the first question we studied, glomerulonephritis. Again, exact reason not very clear. So correct answer is option number C. 1, 3 and 4 is the correct option. 1, 3 and 4 is the correct option in polycystic kidney disease. Coming to the next question. When 39-year-old woman, this is very simple, 39-year-old woman comes with a severe autoimmune hemolytic anemia. Chalo, tell me what is initial step? Initial step in all autoimmune disease. Initial step in all autoimmune disease is prednisolone. The first line of treatment is always steroid. The first line of treatment in all autoimmune disease is going to be steroid. That is for the induction therapy. I'm going to give first line of treatment in severe autoimmune disease is steroid, but only in the refractory patient. The second line considered should be splenectomy. The second line considered should be splenectomy in this patient. But first line treatment remains our prednisolone. All autoimmune disease, the first line treatment prednisolone followed by the splenectomy, that is second line treatment. In the Scober's test, I think just gets easier with the time. There is the Scober's test. In the Scober's test, it is mainly for assessment of which condition? Chalo, type the answer for me. Which condition? है ना, जैसे जैसे क्वेश्चन बढ़ रहे हैं आपका रिस्पॉन्स कम नहीं होने दो, है ना. एक आध रॉन्ग आया तो घबराना नहीं, है ना. एक आध रॉन्ग क्वेश्चन, 10 रॉन्ग क्वेश्चन सबके आने वाले. ऐसा नहीं कि एवरीबडी इज गोइंग टू गेट परफेक्ट. See, in multiple correct answer, there is always this trick that sometime one may get missed. So don't worry. There will be like sort of normalization. So answer this question. Scober's test is used for which clinical condition? Which one? A, B, C or D? Used for, of course, ankylosing spondylitis. It is mainly to check for the lumbar flexion. It is mainly to check for the lumbar flexion. We want to check. In inflammatory arthritis, when we want to check for the spine involvement, look for the spine involvement, axial dominant arthropathy. We will check for the Scober's test, where you tell the person to first measure the length and then tell the person to bend, flexion. Normally the flexion should be more, but if the flexion, the increase in size is less than equal to 5 centimeter, the test is considered positive. That indicates restricted movement. That indicates restricted movement, we can call that. So direct answer, it is diagnostic assessment used in the ankylosing spondylitis. Urate crystals are described as which shape? Urate crystal. Ideally they should mention whether a urine or the joint. So but considering option, we are looking that in the patient with gout, we know patient is having deposit of monosodium urate crystal. There is deposit of monosodium urate crystal is present in the joint. Monosodium urate crystal is always described as the long needle-like crystal. It is the long needle-like crystal that is there. That is seen in patient with gout, while large and rhomboid crystal is seen in patient with pseudogout. Seen in patient with pseudogout, that is due to calcium pyrophosphate. Due to calcium pyrophosphate crystal deposition. Calcium pyrophosphate crystal deposition can give rise to the large rhomboid crystals in the patient with pseudogout. When we look at the patient, next question, direct answer again. Anti-citrulinated peptide antibody is useful for the diagnosis of rheumatoid arthritis. It is the most specific antibody. It is the most specific antibody for the diagnosis of RA. Not only is it more specific, it is also prognostic along with the RA factor. It is also prognostic along with the RA factor, depending on the titers of anti-CCP. The titers of anti-CCP, which are also known as ACP, correlates with the titers of anti-CCP correlates with risk of bone erosion. Risk of bone erosions and deformity. Risk of the bone erosions and deformity. So anti-CCP or anti-citrullinated protein peptide antibody is most specific for diagnosis of RA, rheumatoid arthritis here. So tell me, in other conditions, which are the specific antibody? In Sjogren's syndrome, we have got anti-Rho, anti-La, which is also known as SSA, SSB. In scleroderma, we have got both centromere antibody for the limited form or the topoisomerase 1 for the diffuse form. Centromere for the localized form, topoisomerase 1 for the diffuse form. And in SLE, the specific antibody ANA is essential but only sensitive. It is essential but only sensitive, useful for diagnosis. We can also look at the anti-Smith, which is the most specific. Anti-Smith, which is the most specific. However, it is not sensitive, seen in only 10 to 20% cases. We can use anti-dsDNA, double-stranded DNA is there, which is both sensitive and specific for the diagnosis. Specific for the diagnosis. And we have got APLA, anti-phospholipid antibody. Anti-phospholipid antibody, which is again sensitive and specific for the diagnosis. And just now we discussed one is the low complement level. Low complement level can be used for diagnosis of SLE. So rheumatoid arthritis, anti-CCP. In rheumatology, all questions I keep telling are related to antibodies. Role of antibody. Some are sensitive, some are specific, some are prognostic in nature. Bringing us to question 9. See, one more antibody. Which antibody is commonly associated with drug-induced lupus? Yes, it is the anti-histone antibody. Anti-centromere antibody is associated with limited form of systemic sclerosis. Limited form of systemic sclerosis, also known as the CREST syndrome. It is the anti-Jo antibody, which is also known as the anti-synthetase antibody. Also known as the anti-synthetase antibody, associated with both poly more than dermatomyositis. Poly more than dermatomyositis. And anti-RNP. Anti-RNP, please remember, ribonucleoprotein. Ribonucleoprotein. But we have got different roles here. Among the anti-RNP, if the patient is having anti-U1-RNP, anti-U1-RNP, that is going to be specific for MCTD, mixed connective tissue disorder. But if the patient is having anti-U3-RNP, that is prognostic in patient with systemic sclerosis. It is prognostic in patient with the systemic sclerosis, we can say. So antibody with drug-induced lupus is of course the anti-histone antibody. Bringing us to last question. So from rheumatology and nephrology, we had 10 questions. As said, if you study these two topics, and as you see in renal, glomerulonephritis में 3 क्वेश्चन आ जाते हैं, है ना. उसके आगे एक हमें इनहेरिटेड कॉज, डायबिटिक नेफ्रोपैथी, एपीकेडी, एलपोर्ट सिंड्रोम, इतना फोकस करना है. एंड इन रूमेटोलॉजी इट्स ऑल अबाउट एंटीबॉडीज. एंड कमिंग टू द कॉज, what is cause of acquired systemic amyloidosis? So as discussed again, what is amyloid? Amyloid means insoluble protein. Amyloid means the insoluble protein, and its accumulation its accumulation in the body is amyloidosis. Accumulation in the body is amyloidosis. There is one inherited form, but we are looking at acquired form. Which are the three acquired forms of systemic amyloidosis? Everybody. Which is the three types of acquired form? We have got primary, that is AL type of amyloidosis, where A stands for amyloid, L stands for light chain, associated with multiple myeloma. The second one is the secondary amyloidosis, which is AA type of amyloidosis, associated with A for amyloid, acute phase reactant. So this is seen associated with chronic infections, and chronic inflammatory states. Chronic infection and chronic inflammatory states like rheumatoid arthritis, FMF or FHF, associated with secondary amyloidosis. Chronic inflammation, chronic infection like tuberculosis especially multi-drug resistant, chronic infection especially MDR, XDR TB, associated with risk of secondary amyloidosis. Untreated rheumatoid arthritis, chronic infection, osteomyelitis, associated with the systemic amyloidosis. All of them. And the odd man we know is the dialysis associated amyloidosis. The dialysis associated amyloidosis, where there is accumulation of beta-2 microglobulin. There is accumulation of beta-2 microglobulin is present in this patient. So all the conditions are there. So you have to read the question. What is asked? Inherited form is the transerythrin type of amyloidosis. Acquired can be primary, can be secondary, can be dialysis associated amyloidosis. Right? So these are our questions from rheumatology and nephrology for you. Remaining questions, cardiology questions, the Dr. Arvind sir will be discussing at 9:30. Right? So thank you, all the very best, and join us for the next session with Dr. Arvind sir for discussions about cardiology topic. Chalo.